Thank you for the opportunity to speak in this session on what is new in prevention. In my presentation, I'm going to outline some of the new WHO data, guidance, and global initiatives relevant to the elimination of mother-to-child transmission of hepatitis B, including new data from the progress report, new guidance on country validation of elimination of viral hepatitis, the triple elimination initiative of HIV, syphilis, and hepatitis B EMTCT, and then importantly, the guidance on the prevention of mother-to-child transmission using antiviral prophylaxis, and then finishing with implementations for global scale-up. Well, where we started in 2016 was with the first ever global health sector strategy for viral hepatitis, with an ambitious target for elimination of viral hepatitis as a public health threat, defined as a 90% reduction in incidence of new infections and a 65% reduction in mortality. For both viral hepatitis B and C, this was modeled to be achievable based on the scale up of 6 synergistic preventative and testing and treatment interventions. And for the elimination of mother-to-child transmission of hepatitis B, this would involve the scale up and implementation of the 3 doses of infant vaccination and the birth dose vaccination, in addition to testing and treatment coverage. And with the target of 90% with 3 doses of hepatitis B vaccination in infancy and 90% with birth dose vaccination. Well, what of the new data that was launched earlier this year? And this is new data on the incidence, burden, mortality, testing, and treatment cascade for both hepatitis B and C. What were the key messages? Well, this was based on considerably more data than in previous years, data from 130 countries compared to less than 50 in previous years. New data estimated that there are still around 1.5 million hepatitis B infections each year and around 900,000 deaths due to hepatitis B, so accounting most of the deaths due to viral hepatitis. And in terms of hepatitis B burden, the overall current estimates from 2019 are around 296 million with chronic hepatitis B infection. And of these, around 10% have been diagnosed, and of those, around 22% have been treated. Very importantly, there is now impressive progress towards achieving the original 2020 global target of less than 1% Hep B surface antigen prevalence in those under 5 years of age. And this has been largely achieved and is one of the great public health achievements of the last 2 decades, with a reduction in the Hep B prevalence before 2000 and the implementation of Hep B vaccination, where the prevalence was around 4.7% to less than 1% now. The only region that is not achieving this is the African region, with still a prevalence of around 2.5%. And this has been mirrored in the Hep B vaccination scale up, with now being on track to achieving that 90% target in 2020 for the 3 doses of hepatitis B vaccination, but much less progress on the Hep B birth dose vaccination, with still coverage at around 42% in 2018. So an important development over the last year has been the launch of the new guidance on country validation for elimination of viral hepatitis, with 4 options for countries. Either option A, to pursue elimination of mother-to-child transmission of hepatitis B alongside the goal of triple elimination of HIV, syphilis, and hepatitis B. And option C, pursuing hepatitis B as a public health problem, both the mortality as well as the incidence, and to include hepatitis B EMTCT. And this table illustrates the impact and programmatic targets for country validation. And highlighted in red are the criteria for the Hep B EMTCT, with the impact target of less than 1%, 0.1% Hep B prevalence in 5-year-olds, and the programmatic targets for 90% coverage with 3 doses of Hep B vaccination and 90% with birth dose vaccination. Well, where are countries at in terms of meeting these criteria? Well, the table on the right shows some preliminary data giving an indication by region on where countries are currently at. And if you look at the Euro country profile, for example, you see that many of the countries already are fulfilling that target of the less than or equal to 0.1%, whereas the Afro region still far from reaching that target. And for this reason, and in recognition of those countries that have a high Hep B surface antigen prevalence, and are still far from reaching that impact target, to support and encourage recognition of these countries with a path to elimination set of criteria. This is particularly applicable to the Afro region, and instead for countries to at least fulfill the program's service delivery targets for Hep B vaccination and for hepatitis B surface antigen testing. So this is leveraging the opportunity now with the triple elimination initiative for elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B that was initially spearheaded in the region of the Americas, as well as the Western Pacific region, has now been adopted globally. And many countries are now developing triple elimination frameworks and guidance. And this is building on the opportunity of the shared features of these 3 diseases, enabling an integrated health systems approach for elimination, triple elimination of mother-to-child transmission. And so through achieving high coverage with ANC services, with integrated testing for HIV, syphilis, and hepatitis B for all pregnant women, and linked with a comprehensive integrated postpartum care. And this is a real opportunity to ensure investment into maternal and child health services to leverage on the integration efficiencies to deliver quality patient-centered care. So moving now to the guidance for the antiviral prophylaxis for prevention of mother-to-child transmission. This is just to summarize the series, the sequence and evolving recommendations in this area. Most importantly, in terms of the prevention of mother-to-child transmission, the early recommendation updated in 2017 that all infants should receive the first dose of Hep B vaccination as soon as possible after birth, preferably within 24 hours, to be followed by 2 or 3 doses to complete the primary series. We had recommendations in our overall hepatitis B guidelines for the use of tenofovir, lifelong treatment in those with cirrhosis or raised Hep B DNA and liver enzymes. But at that time, there was insufficient data to support a recommendation on additional use of antivirals. In 2017, we made the recommendation that all pregnant women in antenatal settings should routinely be offered Hep B surface antigen screening, and then more recently that there should be integrated testing for HIV, syphilis, and hepatitis B at least once during pregnancy. So the reason for reconsidering then the recommendation on antiviral prophylaxis was that there was now new evidence from trials and the concerns that timely birth dose alone may not be sufficient to reach the elimination goal of under 0.1% prevalence of Hep B surface antigen infection in children, and the increasing number of requests from countries in the context of a triple elimination initiative. And underpinning this is the recognition of a hierarchy of interventions to achieve prevention of mother-to-child transmission, recognizing that the birth dose and the infant vaccination are the main defense against childhood infections. And that in settings where there can be comprehensive testing and screening of pregnant women, the opportunity, where available, of the use of the hepatitis B immunoglobulin, more so in high-income countries, but where there may be supply issues for this in low and middle-income countries. And then finally, building on that antiviral treatment can make an important difference in prevention for a subgroup of women with high viral loads. So the two recommendations made was that pregnant women testing positive for hepatitis B and who had also a high viral load defined by greater than 200,000 IU per mil should receive tenofovir prophylaxis in the third trimester of pregnancy. And this is in addition to the 3-dose Hep B vaccination, including timely birth dose. The second recommendation was in those settings where Hep B DNA testing is not available, the alternative use of an e-antigen test, and for those that have a positive e-antigen test to also be considered for tenofovir prophylaxis. And this was based on a systematic review, 129 studies, 33 randomized trials, 96 non-randomized, primary outcome of Hep B surface antigen positivity in children, noting that the vast majority of studies were from China, and that none of these studies examine the efficacy of antivirals in the absence of HBV. The overall effect, an impressive effect, was a substantial reduction in new infections with an odds ratio of 0.16, 95% confidence interval 0.1 to 0.26. An additional question was identifying the viral load threshold at which pregnant women should receive the immunoprophylaxis, antiviral prophylaxis. And this graph shows that in the context of women who are receiving birth dose vaccination, infant vaccination, and HBV, that above a threshold of 200,000 IU per mil, transmission may occur. And this was the reason for choosing this threshold for recommending the additional use of antivirals. And then finally, the alternative use of e-antigen test, we evaluated how well the e-antigen performed in identifying those with high viral loads based on the PCR, and showing that the sensitivity was rather lower at 88% with high specificity at 93%. And this slide just pulls together the overall algorithm, and down the middle in the pale orange, representing the pathway for the use of antiviral prophylaxis. And all women, of course, should be considered for long-term antiviral prophylaxis, if indeed long-term antiviral therapy, if indeed they fulfill the requirements in terms of the Hep B DNA and the presence of abnormal liver function tests. So an integrated approach to assessment for both long-term treatment as well as in the setting of preventing mother-to-child transmission, the use of antiviral prophylaxis. So in terms of implementation considerations, important strategies are to really improve the Hep B vaccine coverage, and working with MCH programs to promote hepatitis B birth dose vaccination. There are now emerging opportunities, relabeling for use in a controlled temperature chain, which has been a challenge in terms of implementing birth dose vaccination to date. And the promising initiative from the Vaccine Alliance, Gavi, to promote and support uptake of birth dose vaccination. And although this initiative has been delayed as a result of COVID, It is hoped that this will move forward in 2022, although it's focused on those 50 countries that do not currently have birth dose, and is primarily to support the introduction of birth dose in terms of training and infrastructure support. At the time of the WHO guideline development of the use of antiviral prophylaxis, we undertook a survey among healthcare workers, program managers, as well as civil society on what would be the barriers to the implementation and adoption of these recommendations. And the main barriers identified were really the cost and the availability and access to Hep B DNA testing, as well as the need for training of healthcare workers and improved awareness and awareness raising among women living with hepatitis B, many of whom are unaware of the opportunities with the use of antiviral drugs to further reduce risk of transmission, as well as the limited infrastructure for the testing and treatment of infected pregnant women. And clearly, the implementation of these antiviral prophylaxis recommendations will vary by geographic region. We know from the experience with prevention of mother-to-child transmission of HIV that following the dissemination of those guidelines, that we now have around 89% of pregnant women who are tested, and a high uptake among those who are positive of the initiation of antiviral treatment to prevent mother-to-child transmission, as well as the long-term treatment of the mother. And the implementation of the testing and antiviral prophylaxis recommendations in hepatitis B will, of course, depend on the prevalence of infection in children and in the general population, the current service coverage with immunization, and the availability of and access to Hep B DNA. And in settings, high endemicity settings such as sub-Saharan Africa that currently have suboptimal coverage of infant vaccination, it's the increasing the coverage of timely Hep B birth dose is the absolute priority to achieve the greatest impact at the lowest cost. In contrast, in low endemicity countries that already have high uptake of infant vaccination, with or without birth dose, it is the hepatitis B screening and peripartum tenofovir prophylaxis in those with a hepatitis B DNA that will be the priority moving forward. To recognize that there has been a clear impact of COVID and disruption to maternal and child health services over the last 18 months, affecting ANC deliveries, visits, family planning, and the decreased opportunities for testing. And I'd just like to acknowledge and thank the many colleagues from both within a WHO and external partners who contributed to the development of these and other guidelines. Thank you.